Afternoon, everyone. My name is Steven Dada. Today we'll be talking about obsessive compulsive disorder. It's quite common in our society, even though the prevalence is about 2 to 3%. And the mean age of onset is about 20 years, and it's found to be common within first-degree relatives. And we've seen some comorbidities that accompany this disorder, and they include anxiety, depression, bipolar disorder. Even they could have obsessive compulsive personality disorder, tic disorder, body dysmorphic disorder. And we will try to define what it is. So we have an obsessive, we have the compulsive. Okay, so the obsessions are basically recurrent and persistent thoughts, urges, or images that are experienced at some time during the disturbance. These thoughts are unwanted, they are not comfortable, and they cause a lot of anxiety and distress. The individuals tend to ignore or suppress these thoughts and images and urges, or they neutralize them with some other thoughts or actions by performing a compulsion, and that's where the compulsion comes in. Compulsion is basically repetitive behaviors or mental acts like praying, like counting, like repeating words. You know, those repetitive behaviors can be hand washing, can be ordering, can be checking, that the individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. And these behaviors or mental acts are aimed at preventing or reducing anxiety or distress, or preventing some of the dreaded events or situations. Another thing they could do is that the obsessions or the compulsions are time consuming. They could take an hour, to make sure all the light switches in the house are off and all those things. And the obsessive compulsive symptoms are not attributable to the psychological effects. The disturbances not better explained by the symptoms of another mental disorder. We have various specifiers with good or fair insight. These are people who are quite aware of it. Those with poor insight, a little bit. With absent insight or delusional beliefs. These are people who don't even know or who are not even aware of it. Some are even tic related. Okay. What are the most common obsessions that we see in everyday life? We see contamination fear, pathological doubts, we see somatic dysfunctions, we see need for symmetry, okay, and hypersexual drive. Most common compulsion are checking, washing, counting, need to ask, precision, and hoarding. And the rituals serve to counteract the anxiety induced by the obsessive thoughts. What are the risk factors? Actually, there are no known risk factors. However, certain neurological dysfunctions have been attributed to it. For example, people who have brain injury as a result of an accident, people who have Huntington's chorea, or somebody who have seizures that displays abnormal EEG and abnormal evoked auditory potentials. There has been family history of OCD or Tourette disorder. These are known to also lead to it. And also in the pediatric population, there are people who have pediatric autoimmune neuropsychiatric disorders associated with strep infection, in which we call PANDAS in children, following group A, B strep infections, and is linked to D817 antigen positivity. So how do we treat it? Most of the treatment we use are cognitive behavioral therapy, in which there is exposure with response prevention, ERP, which involves exposure to the feared situation using various techniques like imaginal exposure, systematic desensitization, flooding, with addition of preventing the compulsive behavior. The cognitive strategies include challenging underlying beliefs. Pharmacotherapy that we normally deploy can be SSRI, SNRI, with about 12 to 16 weeks for it to kick into effect and basically have the effect on the individual. Chlorphramine can be used. Adjunctive antipsychotics like risperidone for refractive OCDs can also be used. There's been talk about neurosurgery or neurostimulation like anterior cingulotomy for severe refractory OCDs. Two techniques have been deployed also. We have radiofrequency thermolation and gamma knife capsulotomy, in which there has been about 50 to 70% response rate. ECT, particularly for those with comorbid severe depression, has been used. However, when we talk about the prognosis, it may be refractory or chronic with waxing and waning symptoms, less than 20% remission rate without treatment. So this is basically what we know currently about obsessive compulsive disorder. Thank you very much.